Welcome to the Power of Africa Conference 2023. My name is Lillian Morenike Oduole. I am a Nigerian born, currently residing in America. I'm a family nurse practitioner and owner of Dove Hydration and Wellness and Lillian Morenike Consulting. It is a pleasure to be here, and I'm so excited to invite and introduce our esteemed panelists on today's health session. First off, we'll have Winnie.
Thank you so much, Lillian. I am excited to join you. My name is Winnie Maina from Kenya. I am a clinical dermatologist and the founder of Gelat Aesthetic Clinic, where we purely deal with cosmetic medicine and reconstructive medicine. I'm really honored to be here and I'm excited to join the rest of us as we have this conversation about health. Thank you so much.
You're welcome. Thank you so much for being here. Last but not least, we would like to invite Dr. Faith Mumba.
Thank you so much, Lillian. My name is Faith Mumba, one of the junior doctors from Zambia. I've been working for 2 years now as a junior practitioner, not yet specialized. I'm hoping to specialize in family medicine or pediatrics soon enough. And I'm excited to be here with everyone. Thank you.
You're so welcome. Thank you so much, ladies, for being here. Now, let's get into the topic. So, the topic for today's health session is the innovation of precision medicine genomics in modern Africa's healthcare delivery system. Let's start off with Winnie. I have a question for you. What are the barriers to implementation of genomic medicine in Africa?
Thank you, Lillian. That is such a good question. When we look at the genomics medicine and precision medicine, we seem, especially the healthcare practitioners in Africa, seem to have an insight or some form of knowledge, but not comprehensive knowledge, especially at the implementation phase. So I think top on the list is insufficient knowledge, insufficient specialized practitioners, especially in the line of genomics and genetics. But yeah, that is something that can be addressed.
Thank you for that.
Thank you.
Thank you. Dr. Faith Mumba, I would like to ask you a question. What is precision medicine? A lot of times there's so many different facets to healthcare, especially being abroad. We're so exposed to a wide variety of healthcare. But in Africa, what does that precision medicine mean?
Okay. That's an interesting question. To answer your question, I would say precision medicine, we're talking about a sort of personalized medicine. So this is the type of medicine which is tailored to an individual. So we're trying to tailor it to an individual's phenotype. That's how they look, their genotype, that's their genetic makeup, their environment as well. There's so many factors that can affect the precision medicine. So the good part with this is that you will optimize on the outcome, the treatment outcome of your patients, which is something that we've had a challenge with when you look at Africa, because when you talk about genotype, okay, there was the human gene itself, the human genotype sequencing, which was which ended in 2000, which was concluded in 2000, was done on non-Africans. So there is that there's that we have that challenge because we are talking of doing research on someone who's not African, and you bring that medicine to Africa, and you're treating people with that medicine which wasn't trailed or tailored on Africans. So you have that challenge because at the end of the day, we're going to see a lot of side effects. We're going to have a lot of side effects on our patients. So there's need for us to come back to our roots and do more research on our gene. What's our gene like? And I remember reading something recently in 2019. They were looking at the African type of gene, and they found that our gene is almost about 10% different from the gene that we are currently using. So we need to really go back and try to work on that.
You know, you brought up very valid points, because how can we be given medication that is not even designed for our genomics, you know? And it's so unfair, right? That Africa is always the last on the list, or more of like the guinea pigs for
Yeah.
these trials, clinical trials. So thank you so much for that. Winnie, would you like to add to that?
Absolutely, because when you look at the representation of the African race in the research, that clinical research right now, we're talking about 2% of the African or the Black population representation. This is quite an underrepresentation, and you see whatever we use in terms of medication, whatever therapies that we are using, if they have not been tested or sequenced in the African genome, what are the chances that we could be directing the wrong treatment plans or the wrong treatment options for the wrong diagnosis? So I think this is something that we need to bring on board, scaling the African or the Black representation, especially in the genetic sequencing, even before we come henceforth with treatment modalities for different pathogenic variants for different diseases.
And
Absolutely.
also, just to add on Winnie's point, we see we're having a lot of cases in when it comes to cancers. And we're talking about cancer. We have a lot of cancer cases in Africa, and that is one of the things that really needs genetic studies. And you find that even for cancer, there are different types of cancers, and there are different genetic makeups for that cancer, and how you treat it will also vary depending on the type of cancer, its genetic makeup. So even its effect on our gene, our human gene as Africans, will be different. So we need to do more research on that, so that we can be able to treat our patients well. When you look at the cancer treatment outcome in developed countries as compared to ours, you find that in developed countries, people are able to get better. They recover from cancer. You see a lot of testimonies. They recovered from cancer. But why is it different from us? Why do we have so many challenges when it comes to cancer treatment in our setups? Yeah.
That's excellent. You know, cancer is something that has really evolved over the years, especially with the new treatments and innovation in medicine. So to get to the cellular level, the DNA level to treat is key. So thank you so much, both of you, for answering that question. Dr. Faith, I would like to pose a question to you as well. What are the challenges that can be faced with precision medicine? Currently, the state of Africa now, we're not really, we're light years behind in the innovation. So what kind of challenges are you experiencing currently in your practice, and that you can see in other countries in Africa?
Okay, so some of the things were talked about by Winnie. She talked about specialists, trained specialists. So when we look at that, we don't have enough trained specialists. Already, we are struggling with just having enough doctors in our countries. For example, our country, we have very few doctors. We have like one doctor per 12,000 patients, which is quite overwhelming. And now we're looking at having trained specialists in genetics in these types of studies, which would take some time. So it is a challenge on that part. And we're also looking at trying to bring it down, personalizing these treatments to an individual. So that would lead us to having a lot of medical data, a lot of medical information. So how are we going to manage this information? But the good part is we are living in a world where we now have artificial intelligence. So if we can also incorporate that in our medical practice, that will really help us a lot. Because when you look at artificial intelligence, you are able to incorporate all that medical data and be able to have access to it at a faster rate, as compared to manually doing all these things. The other challenge that we may pose is finances. When it comes to finances, that's a very huge challenge. When you look at the first genotype sequencing, which was done, which ended in about 2000 to 2002, it started in the 90s and it ended in 2000. That took up a huge amount of money. And for us to do that, to just do our own research, it would require a huge funding, and people have to come on board to support this. But I believe there could always be a solution when you talk of finances. If we were to collaborate with EU countries, developed countries, where they've already done this before, it would help on our part as well. Of course, we can't just say we're going to do this alone, but if we were to partner with these countries who are well developed when it comes to such type of medicine, I think that would help. I think that those are some of the challenges that we would face. Yeah.
Excellent, excellent. Whitney, would you like to add to that?
Yes. I would like to add something to that. I'm from Kenya, and I'm not sure whether the modality of healthcare training institutions are the same across board in Africa. But what I've been able to notice is that our training, especially in terms of testing and evaluating diseases, right now is usually targeted on age. Like, it's age-based. If I'm to start screening a patient on cancer, if I'm to start screening a patient on diabetes, if I'm to start screening a patient on hypertension, we seem to have pegged the testing modalities basically on age. What else if we would bring the precision medicine and the genomics into the preventive level of care? I think the impact would be greater other than even the treatment modalities. Take a case scenario whereby in the family history there is cancer, and we are able to do the genetic typing for maybe the next of kins, the family members, the brothers, the sisters. We are likely to isolate this genetic predisposition even before it gets to the pathogenic variant. So I think we need to shift the focus from the treatment level and bring it to the level of preventive. And I think the impact will be larger than the way we do in terms of treatment, because right now the diagnosis of cancer or any other major chronic illnesses is almost a death sentence, because again, like what Dr. Faith had said, how we treat cancer, it can't be a one size fits all.
Yeah.
You see, we have the same DNA, yes, but the transcription to have esophagus, cancer of esophagus, the transcription to have cancer of the ovary or the gastric cancer is totally different. So the aspect of having chemotherapy as just a broad way of treating cancer, or just radiotherapy, you are using the same for cancer of the esophagus, you're using the same for cancer of the stomach. I really feel that it should have been approached differently, because these are different diseases. They'll require different treatment so that we are able to achieve something remarkable. But otherwise, as we are at, the mortality and morbidity to these diseases, it's quite significant and very worrying.
Yeah.
Yes, absolutely. You brought up an excellent point, which is prevention medicine. You know, would you say that some of the herbs and the food that we eat in Africa are a form of preventative medicine? How do you look at our food and our diet for prevention of medicine? Anyone can go.
Okay, I would take it up. So there's one thing that we realized these days, which is we have a lot of non-communicable diseases, which wasn't the case back then. And whenever we are looking at the risk factors for some of these non-communicable diseases, we are looking at our lifestyle, the type of foods that we eat, the type of life that we live. So now we have a high rate. We have a high rate when it comes to eating junk foods these days, processed foods, which wasn't the case back in the days with our parents. The reason why we didn't see some of these diseases back in the days. So it has an effect. With the type of food that we eat has an effect. We're always exposed. These days, there's an increase in industrialization. So we have an increased exposure to pollutants, which wasn't the case back in the days. These days, you can easily see people smoking, freely smoking. And that has also increased the risk of them having lung cancers, which wasn't the case back in the days. So what we eat really does matter. Back in the days, would eat less processed foods, more of health, nutritious foods, as compared to these days. We are eating fast food, junk foods, everything that isn't healthy. And it's the reason why we're now seeing a high rise in, or let's say, gastric cancers. We are now having a lot of cases of gastric cancers. You come across young people. Young people are now having cancers. Back in the days, you'd see cancers in elderly people. Even these days, we have that notion that for you to suspect that it's cancer, it has to be somebody maybe above 60s. But these days, we are seeing young people suffering from some of these cancers, and it means we are really going. We are moving from a certain type of lifestyle to a lifestyle that is quite dangerous. So we have to look at that as well. Yeah.
Excellent. Thank you. Winnie?
Yeah, interesting. So especially on the diets, like what Dr. Faith has said, we're looking at precision medicine. If we combine this precision genetic typing together with the food, I'm sure the conversation about GMOs is still not very accepted, but it's something exciting. I'll be having a close look on how it evolves, because basically we've seen patients, or probably you have encountered, whereby I am 30 years old. We have a genetic predisposition. Maybe let's say we call it gastric cancer.
Yeah.
And two people, myself, let's say my sister.
Mhm.
And you find Winnie has been identified with the pathogenic variant at 30 years old, while her sister, same genetic predisposition, runs all the way to 70 years.
Yeah.
They are in the same environment, have been feeding close to the same things, but we essentially ask what could be the changes, or what could be the issue whereby we have having some people presenting with the pathogenic variant of different diseases early in life, while else we have others 70-year-old, same exposure, but they do not have the pathogenic variants. So the issue of genetically modified foods, could we be getting into a situation whereby Lillian can go on the shelf and have type A flour, which Winnie needs type B for the same? Because again, we're saying we might be made of the same DNA, but we have more than, like the science say, we have more than 4 million differences.
Yeah.
If we are saying we are moving to types of the precision medicine, in terms of preventing diseases and treating diseases, I'm looking into an aspect whereby in terms of even what we consume, environment, and other epigenetic factors will probably in future be different. And it's quite an interesting thing that we'll be looking at.
Yes, excellent. Winnie, I have a question for you. What are the actionable recommendations to successful introduction of genomic medicine in Africa? So, what can we recommend from a healthcare perspective for Africa to implement such things, such as the precision medicine?
Right. I see we have mentioned of the workforce training, we have mentioned of the infrastructure, but I'd like to major on the translation of research, because you find that we know, or we have an idea there is precision medicine. My colleagues, I talked to a few, they have an idea of what is precision medicine, they have an idea what happens in genomics. But if you try break down and go into details what exactly it entails, there seems to be a knowledge gap. So I think we need to start with the translational research. Do our population understand what exactly is precision medicine? How exactly is it going to come and fit in the current healthcare systems, and how is it going to help them? If like right now, if you need to bring a research on something, we cannot start it the top tier of the healthcare practitioners, the person that we are gonna approach just to get the samples, the specimens, and all that. They need to understand what is the impact in terms of to them as a person, to the healthcare system, and to the future generation. Such is as well as the healthcare practitioners. We have laboratory technicians, we have nurses, we have doctors, we have specialists still have an idea of what is precision medicine. But if you go into the translational research, I am sure they'll get to understand the impact and we'll be able to bring it at the populational level and including the policymakers and the public will be willing to participate, just as if they understand where we're coming from.
You know, I would even thank you so much for that, Winnie. I would even propose that, the African trained providers, doctors, nurses should come to America,
Yeah.
should have the opportunity to
Mhm.
get a visa, get this exposure in American medicine, or in even European medicine, where you can come for an externship so that you can see what is the current practice of this precision medicine, of the genomic medicine. And, with that knowledge and that exposure, just like we go to continuing education conferences here in America, we take that knowledge back to our practices to expound upon and to implement. So if that same opportunity, that visa, that exchange or externship is offered to the African providers, I think that that will be a plus to the African healthcare system. Many colleges do exchange of some sort.
Yeah.
So, I just throw that out there. We hope that our African leaders would look into such things. Dr. Mumbo, what would you like to add to that?
Well, I totally agree on the aspect of research. I believe we have a lot of physicians, doctors, researchers, health workers that are well able, that are capable of doing this and coming together as a multidisciplinary team and pushing for this. It will surely go through. We just need to build that interest in us. We should have interest for this because it's very important. As the world is revolving, so is the medical practice. It's also evolving, and we need to change the ways of which we treat our patients, the ways that in which we think, and also how we operate. So we really need to come together and do more research on this. Yeah.
Yes, thank you. We're so behind in Africa with our healthcare, and for instance, in Nigeria, there was some discussion with some friends recently about how private hospitals were just practicing ill medicine. They were not practicing appropriate healthcare, and unfortunately, many of those friends and family members had passed away because of the negligence from the staff. Right. So, who do we hold accountable? Is it the practitioner? Is it the government? There's a lot of issues with access and accessibility. A lot of people would travel outside of Nigeria, 4 hours flight to get to the nearest modern day hospital, with all the resources and the wealth of how rich Africa is, just being a wealthy nation, right? A wealthy continent. How is it that, healthcare, the very thing that keeps us alive, is so deficient, is so depleted in our great continent of Africa? How is it that what we need to sustain our livelihood and what we need to sustain our actual ability to breathe and to function, how is that the last thing on our list, or the last thing that our government is looking to improve, as opposed to selling our resources to other countries or allowing other countries to come and do however they would like? So the question I pose to you both ladies is that, what message do you have to the government on how to improve the healthcare system so that it is no longer on the back burner, but more on the front line, so that we can sustain our lives?
So I would say we need the government to come down to our level and try to have to liaise with the health workers, try to talk to them, try to find out what challenges are you facing and where can we work with you so that we can improve the system. I think instead of just being more focused on the government side of things, it's best they also come on our level. They try to understand, because at the end of the day, we might have more information than our government. So if they come to us and ask for such information, they provide that platform where we can freely air out our grievances. We can freely tell them what we need, what sort of help we need from them. That would be very helpful on our part as well. Yeah.
Thank you for
All right.
that. Winnie, how can you answer
Um,
that, please?
my thoughts probably a little different is that we understand that we are limited in terms of resources, especially if we are looking at the precision and genomic medicine, which is likely to bridge a gap in terms of treatment, diagnosis, and even being able to completely heal or cure the very non-communicable diseases. So my focus would be more on preventive medicine, as if whatever we're talking about today, the precision medicine, we're able to bring it to the level of the preventive level, the tier 1 health facilities that we see in the villages, in away from the modernization of the cities, that we are having genetic counselors, our health care workers have been equipped in knowledge, because the gap we have with the healthcare workers that we have in the system right now is that genetics or genetic medicine is viewed to be either very expensive or it's likely to benefit the affluent, or what we call the rich in the country. So the uptake becomes very limited. So if we go and sensitize the public that we are at the very points of entry in the community, that we are doing this screening so that we can prevent the disease. Because again, the economic burden of this, treating the disease is way more higher than even the preventive medicine. So I'd rally the government or the stakeholders in terms of healthcare system. Let's go back to the preventive medicine aspect other than focusing on the curative. Because I see we go overboard and buy, what we call the PET scans, the MRI, very sophisticated methods of investigation and diagnostics. But just what could be if we approach this aspect from the preventive level, and maybe the price and the cost of bridging the gap at the preventive level will be way lower than what we would have to invest in buying the very expensive treatment options or treatment modalities just to treat a disease that we would have prevented if actually we went to the community level in the beginning.
Excellent. Thank you very much for that. Today's topic was the innovation of precision medicine, genomics in modern Africans' healthcare delivery system. And I believe we answered that question. We've dived deep into that discussion very well. Any last remarks, ladies? Dr. Faith?
Well, I would say after this discussion, I hope it just opens up a lot of people's minds as to what preventive medicine is, and we'll see more people will be interested in reading up on more of this and doing some research. I know we are far from reaching a certain goal where we can reach precision medicine or personalized medicine, but there's so much that we can do for now. Like Winnie said, there's more work on preventive parts instead of reaching a point where we need curative medicine. It's better we try to work with what we can at the moment, and also continue doing more research on this as well.
Thank you. Winnie?
My point will be, I'll rally every African or every Black listening to us at this point in time. Can we just participate more in the clinical research that we have, or any that comes by? Because basically we're talking about 2% representation. If we're having 2% globally representation, how again do we expect to get the modern or right-sized treatment options being delivered to us, the Blacks or the Africans, while we did not participate in the first time, yeah. And then again, if the research was done from a non-Black or non-African, what are the chances that that may not work for us? Can we participate more so that we are able to bring this home, so that even the treatment options and the therapies that are coming on board every now and then, because technology is really growing and it's something we're looking at, can have us involved, and I'm sure we'll be able to enjoy better healthcare.
Excellent. Well, thank you very much, ladies. You both were amazing. This was such a fruitful conversation on this health panel, and I really appreciate your time and your service to the communities of Africa. Thank you.